gå till på internat i Skottland. Okej, tack så mycket.
Tack så mycket. Yes, my Swedish is good enough to understand what the task was that Mikael gave me. So it's always good if someone gives you a Swedish title that you understand enough to know what you have to do. But if I would have to speak in Swedish, it would probably take double the time. We just said that before. So I'm very grateful that he said, yeah, you kan prata på engelska om du vill. So I take that opportunity and rather speak in English. Although it's not my first language, as you know. I have done all my training in Germany. I grew up in Germany, did my psychiatry training in Germany, specialized in it, worked in Germany. But I don't know how many people have worked or lived in Germany. We have our very own traditions, and the medical tradition in Germany comes literally from the Prussian military lazaret. And that structure is still there. So we still have our Chefarzt, the superintendent who dictates everything. And even if you are already a specialist, you have to follow those rules. And he may come in a coat with golden buttons, and I've still seen that. It's probably no longer the case, but it was actually at the time. So I had a part of my training in England and some part even further away in New Zealand, and I saw that you can do medicine in a different style. You can do it in a very team-orientated style, in a very democratic style, and that appealed a lot to me. Because as Mikael said, yeah, I do love people and I do love to communicate with people. And I learned that it usually helps you to come to the right conclusions if you talk with others and if you work in a team. And I suppose that most of you that have come today do work in a team and appreciate that as well. The way how I came to that place in Castle Craig where I work now may be part of the theme I'm about to talk. And that's why I thought I'd tell you a bit about the life career I had. As Mikael has said, I have very early been torn between, shall I do music actively or shall I follow the medical route, which I was contemplating soon? And for not being completely split already and develop schizophrenic symptoms, I just decided, well, do both then. And I studied medicine, and in the middle of it got quite upset with the very rigid way how we had to study and said, no, I need to stop this for a moment. And in the middle of it, I went to the music conservatorium in the neighbor town and studied music. Then I realized I miss the academic approach of university and thought, okay, if that's the case, probably you have to go back and finish your studies, and then you can still see what you do. So I went back and finished my medical studies, still continued with my music, and realized you just need to give it a bit more time. Don't be just too much dragged by the efficiency ethos that our society has developed, but take time for things. And actually, that is something we need for our patients. We need time. And if we are always pressured to do it as quickly as possible and on the cheapest possible, it's probably not what our mind wants. So that was already a learning curve within my study time, that if you don't give yourself time, you may get depressed. And then I met a doctor, a neurologist, who offered me to work in his hospital, which he had started to do a PhD. And at the time, it was the question whether computerized EEG the registration of the electric waves of the brain, whether that could be recognized with a computer system, automatized, so you wouldn't need a very experienced neurologist specialist to see what the risk of seizures is when you do a detox, particularly from alcohol. If you do alcohol detoxification, one of the most serious problems that could occur is an epileptic seizure, and you want to really avoid that. The sooner you get the idea that there is a rising level of it, you should act on it. So an automated system where you just push the button, put the electrodes on the head, and get an answer would be great. We are talking now some decades ago when I was a student, and computer storage was still with floppy disks. Do you know what a floppy disk is? Not everyone will know this here, but some will do. So you can imagine what the storage problem was if you had to do it on floppies. You know? So it was interesting times. And what it did to me, it brought me into a hospital for the detoxification of alcohol-dependent people. This is not something that you would have heard of in your medical studies. That did not really interest anyone, apparently, and I had not, I think, a single lecture on the treatment of addiction when I studied medicine. So if I hadn't had done this, I would probably not have come in touch during my study time with that field. But this got me into this very special psychosomatic hospital, I would say it was already. And the reason why this hospital existed was that this professor, Professor Gottschalk was his name, he himself, he was an absolute high flyer. He was the youngest professor of medicine at the time. In his mid-30s, he became professor of neurology. But it had a price, because again, he didn't give himself time. He rushed. He started to drink to get himself down. He developed a massive alcohol problem, crashed completely, had to quit the job, and he struggled immensely in overcoming it and in getting treatment that would help him. And he was so frustrated when he came out of this that he thought, this took me 5 years, and this is totally unacceptable that a professional would not get the help that you would really want. And he flew around in the whole world. He went to South Africa and to America, where there were quite different approaches to the treatment of addictions than at the time in Germany. So he went from hospital to hospital that interested him and put together something that he thought, what I see here is good, that was good, and put this hospital up, opened his own concept of treatment of addiction, and that was the place. And I was very fascinated by the integrated approach he had in this place. There was lots of psychotherapy happening already at the time when people were coming in for the detoxification. And I thought it was very interesting how the whole thing was set up. So different to what I heard in somatic medicine and in psychiatry in the university when I was studying. That got me hooked, if you excuse the pun. And I got addicted to that way of looking at treatment and medicine, which was very, very different. So that was the starting point when I was still a medical student, why I thought working in addictions is a very, very worthwhile and interesting field. Then I worked in Germany, various places. As I said, I had the opportunity to, a bit similar to this, my doctor father, as we say it in Germany. I worked in a general psychiatric hospital in the countryside in Bavaria. And usually that was the time in the 90s when hospitals shrunk. You had to give away beds, you couldn't keep them. And suddenly the government said, well, you have a huge building there. You can get additional 20 beds, but only if you do it for addiction treatment, because we do not have enough in Bavaria. So the superintendent, Chefarzt, not so many golden buttons on his, he was quite nice. He said, Florian, Dr. Kaplik, I know from your CV that you've worked in addictions, you've done your PhD. Would you be interested to do that unit? And I said, yes, I think that's a fantastic opportunity. So I said, okay, so you can have a unit of 20 beds if you devote that to opiate treatment. So this was a specific unit because Bavaria was flooded with opiate users and didn't have enough places to treat them. And I did the same thing that I had heard my PhD father had done. I took a psychologist and a nurse and a doctor's colleague, assistant doctor, and said, okay, I would like to go with those three and drive around the hospitals in Bavaria and see what other places do. And then it would be great to put something up from what we've seen that we would think would be really good, avoid the mistakes and try to set up something nice. And we did that, and I can only say this is the best thing you can do in the world. If you get the chance to start something, look at many places, what people do, and bring it together, sit together, and set up and write a project. And that's what we did. And it was a concept to ideally have patients for 3 months and have them in an integrated unit where we do detox and psychotherapy parallel. And from what I was so fascinated when I saw the first place of it. So these ideas have been there. In between, I've always been doing normal madness, what I usually call general adult psychiatry. And so I was always going between fields, which I again think it is very stimulating if you do not only fix yourself to a very narrow field. Keep yourself open, keep your mind open, go to other things, do this, do that, and bring that together. I really think it's good for all the other things and for the one thing. Our brain is a very open system, so feed it from many channels. And also was saying that, yeah, our brain can be influenced by chemicals, it can be influenced by just speaking, by words. It can be influenced by only what you see, art. Use the visual in treatment. I think it's very important. We do that in Casa Craig as well. Use music, use the oral. Use touch. Yeah, we have horses in Casa Craig. We have what we call, well, not what we call, but what is equine therapy. The brain is an amazing organ which has so many ways of being touched and being able to communicate. Why only using one channel? Why using only chemical? Why using only ECT? The man that came to Åsa and said, well, give me ECT and then everything is fine. Made my thoughts going away. Well, you should see, whenever you see a human being coming to you, listen, and then see what channels would be the best channels for that individual to use. And for some, it may be the words, and for some, it may be the art, and for some, it may be music, and for some, chemical may actually be very important. The thing is to not be too biased by what you've studied, heard, got money for. It's many ways that can bias you. Try to keep your mind open and to be not too biased and see the multitude of things that are available. My slides are not in a way that I have to go through every slides. I just put slides up to help me every now and then or to illustrate something. And this may be something to make you smile, but also goes with your first lecture also. There's other ways to treat depression. So you may be surprised if you go to a pharmacist and you ask about an antidepressant and he brings you a dog. Well, dog therapy, animal therapy, may be the thing that helps you and makes you start probably seeing something totally different in the world that you may have not seen before. So jokes, cartoons, many things can help us think differently and use different things. But the main theme that Michael asked me, of course, was to talk about how do we do it. What's the title? Medicinering och avgiftning I internatbehandling. Right. I personally think that detoxification, avgiftning, is probably best done in a hospital setting. And in a place like where I work at the moment at Castle Craig, the great advantage is we are in the middle of nowhere. This is the so-called borders of Scotland. The borders, as the name says, it's between England and Scotland, and you have to walk a long way to find the next village, the next pub, or let alone a dealer. So if you're there, no access to anything. We do not have to lock the house. We don't lock our house. People come there because they want to be there. It's not a psychiatric unit where you can be detained by law. If that happens, that someone gets so psychotic or so suicidal, then we have to refer patients to a psychiatric hospital. We can't do that. Apart from that, we can do a lot at Castle Craig. It started small 30 years ago, I think, with 15 or 20 patients, and it grew over the years. And now we have, I think, literally beds. We have 90 or 100 beds. We are hoping not to fill them above 80 because then it gets crowded and cramped. And you do not only need time, you also need space to be an individual that can grow, I think. And the advantage of having a larger hospital for that purpose of beroendebehandling is that because we have so many patients, we have a large team and we can do the complete medical detoxification program there. We have nurses on all day and night. We have a medical doctor 24 hours all the time on site. So we are relatively well geared up for the medical problems that can occur if you do detoxification. And what we do is we do medical treatment as well. You have to do good medical treatment if you detox someone, particularly from alcohol. Very tricky can be GHB. Benzodiazepines can be tricky. Opiates can be unpleasant for the individual, but not dangerous. Whereas alcohol can, of course, be very dangerous if you do. I do not know how much I should go into details, because if I understood right, we have 4 doctors here and the others not. You would need to tell me if you want to know in more detail what we do. I'm more than happy. Please ask questions anytime. I'm doing my talks never as a robot. So you can always interfere if you want to ask anything. Because I could go into details what techniques we use, but I don't know how much you want to know that. You want to know techniques of detoxification? Arms up? Yeah, okay, quite a few. Okay, so we do, in a way, what is the standard in the world to do that? There's a German saying, we only cook with water. There is no other thing you can cook with. But you should still think how you apply it. So if someone comes in with an alcohol dependence syndrome and needs detoxification because he has physical withdrawals, you need to see how you can keep those low, because you don't want an epileptic seizure. You don't want someone to go into a delirium tremens. The patient sometimes arrives with us still intoxicated. That means you have to be careful. You don't want to oversedate this patient. So we need to check what the blood alcohol concentration is. And when it comes down, and we are satisfied that it comes down enough, and then withdrawal symptoms come, like the tremor and the sweats, you want to catch them early and not to go into hallucinations, because then delirium could happen. So what do you give? We give benzodiazepines, which have a similar way of action as alcohol is, but we can control it well. And with these well-controlled giving of benzodiazepines, you can usually control the symptoms quite well. You sometimes have to give blood pressure medication as well, because that can really go up. It is physical stress for the body if you get into withdrawals. So you need to treat that well with medication. A lot of hospitals, in the UK at least, have a very fixed regime. They give 4 times 40 milligrams Librium, and then you see. That is a good dose that would keep most people. The thing is, quite a few people would be oversedated with it. They don't need that much. So we have the luxury, we have enough nurses that are there available in the night as well. We check our patients all the time, and we only give as much medication that is needed and not more than is needed. And I think that is the most sensible approach that any doctor can have in any field that he's working. Give as much as necessary, but as little as possible. And if that is your mantra, you would always think what you do. And polypharmacy is really not the thing to do, as you have said also, give another one, give another one, give another one. No, sometimes you may rather give less. Patients arrive in our place sometimes with ridiculous amounts of medication. I mean, it's the nice word in British is it's mind-boggling, really. 2 different antidepressants, 1 or 2 antipsychotics, a hypnotic like a benzodiazepine, a blood pressure medication to keep anxiety and blood pressure down, and all that together. And there can be so many damaging effects if you take all these medications all together about the interactions. It is usually a sign of the helplessness of us helpers. If that happens, you have patients that struggle. And if it's outside an outpatient, you often only get half the story. You cannot always blame the team and the doctors for what they've done, because they may not have known what was really going on. Sometimes people don't even know about the addiction, about the consume patterns. But still, if someone comes like that, we always have the discussion on the first day with our patients. We say, look, if we really want to understand you and you want to understand yourself, you should have a head that is as clear as possible from any substances that influences your thinking and your feeling and your decision making. And we have a hard time in these discussions to convince a patient that we do not want to deprive them from what they have acquired. Yeah, but a doctor prescribed it for me. I need that as medication. And I usually tend to say, I appreciate what has been given to you before. But now you are in the good position that you've come to a safe place where we will look after you, and we will make sure you do not struggle. But here you could afford to come off these medications again that really influence you in a way that you don't know yourself, you don't know who you are. And we also don't know who you are, and I struggle making a diagnosis. Usually I don't make a diagnosis. Well, I make a working diagnosis on a first day and say, look, this is probably what we see, let's do this. But we will develop that through the time you are with us. We will speak again about what are your problems, what diagnosis might be coming at the end. Yeah? A diagnosis is a concept, I think. It shouldn't be a label with which you go away and you can get disability allowances and whatever. That's what these labels are used for. Our insurance companies and the social system forces us to use it. But what it really should be, it should be a working concept for the people that want to help others, on which they have a common understanding what we should do, because certain measures have a certain basis for which you use them, and that's what we call the diagnosis. So we are wandering away. If you start with talking about addiction, you always realize that it's a huge, complex thing. Treating addictions is not a one-way road. Treating addiction is always a very complex approach, because it is an illness that affects the whole body with the brain. So it is a complex thing. and therefore you usually have the complex approach. Coming back to that early phase of detoxification period, when people come to us, it depends on how intoxicated they are. But ideally, we start with the psychotherapeutic process on day 1, or let's say day 2, day 3. Again, I think the advantage is not everyone is already 100% motivated to do the rehabilitation program when they arrive with us. Ideally, they should, but, well, realities are different. And you get someone best involved. We all know that from ourselves, don't we? If we are vulnerable, we are most open. If we have our defenses up again because we feel strong, we are not as easily reached. And therefore, if you're in the vulnerable phase of early detoxification, when you're just starting to get off these substances, in this weak phase, you're open to talk about your situation. And if you then have contact already with your therapist, that will work much more when you're abstinent and sober, that is a very good phase of making contact and getting in touch. And therefore, we try to get our patients in the full program as soon as they can walk good. Yeah? And they may just sit in our groups and not be able to say much, but they don't have to. But they are immediately part of the therapeutic community. And I think that is the most empowering effect of everything. When patients come to a pre-admission session with us, which we like to do, we very much appreciate if patients would come with their family caretaker for a pre-admission assessment, but most of the times we have to do it over the phone. But we always encourage them to be open to our concept that taking part in the groups is the crucial point of coming to treatment. We are not, what I usually use as a metaphor, we are not a dry cleaning facility. You bring your jacket and you take it away in 5 days and then it's clean. No, we are a facility that enables you to do your washing, but you have to do the washing yourself. And how clean you leave this place depends on how you do the washing process with the tools, with the washing machine that we provide for you. People look often a bit, oh, right, okay. Particularly families would much rather have us as a dry cleaning facility. We pay you that money, and when we have him back, it's all wonderful. Human beings don't work like that. So you have a lot of interesting conversations in the process of our treatment. But I fully believe that the work in the therapeutic community is the strongest power of an internatbehandling. And it's probably also the safest way of doing it. If patients come with opiate dependence, we discuss the way to do it. Some patients may come only with heroin use, and I would usually recommend that we then switch that over to buprenorphine, Subutex, Suboxone. I'm sure it's used here a lot as well in Sweden. And I think it's the safest and the best way to do an opiate detoxification. But if patients come already on methadone, and I must say I've seen ridiculous doses of high-dose methadone prescribed, admitted someone on 180 milligrams a day. So it's absurd to what amount you can go. Again, out of the helplessness, the patient's still struggling out there, and the doctors prescribe more and more. But it's helplessness. Yeah? But anyway, you can do it from any high dose, whatever, if it's established that this dose has been given. But you need to be very careful. Methadone is lethal. and deaths have happened in behandlingshem. So you need to be very careful with this. You need good confirmation from the pharmacy. I would never give... Is it a question? Oh, I thought. We would then continue methadone and dose it down. It can be done much quicker than most people think. If someone comes from a high dose like this, from 180, you can easily take 50 off, give him 120 the next day, 100, 80, 60, 50, 40, 30, 20, 15, 10, 8, 6, 4, 2, off. That is no problem. Do you know what the problem is? Our mind. Patients think, this is impossible, I'm going to die. But actually, no, you're not. And the way how I learned this, because, you never know, maybe they are right. What do we know if I've never used it? But there were some patients through the years I've seen who were incredibly dedicated. They have done many detoxes before. And so this guy walked in, he was on only 50 milligrams. And he said, I'm sick of it, I have done it before, please, can we do this in 3 days? I said, what? I said, yeah, I know me, listen, I'm in a good place here, I know this, and give me 40, 15, 5, and that's it. I said, okay, so we can still see it. That is not dangerous. Dangerous is to give too much. That can be lethal. To give too little may cause some withdrawal symptoms, but that is not the problem. So I said, yeah, okay, I'm fine, let's do that. And he went through it without any problems. I mean, I was so amazed. We took it down that quickly. Yeah, he was not really well that day. He didn't feel okay, but he said, that's fine, I'll be coming around. And with patients like this, I learned that if your mindset is really geared up, that has an incredible influence on the physical symptoms of withdrawal. So what does that teach us? In the sense that Åsa has said, you can influence your brain in many ways. And the brain has an influence on how the body reacts. And it can be amazing what you can see. And that's why I think it is so important that anyone who does a detox has good mental care at the same time. You need to be there. A team needs to be there and help the individual. And you need to be able to talk to everyone. And then you can save an incredible amount on medication. Good psychotherapy saves tons of medications. The interaction of medication, because I see it's going towards 12, and I'm sure you will soon have rumbles in your tummy. This is the latest copy of a very good journal from the English publishers, Oxford University Press. Alcohol and Alcoholism is the journal of the Medical Council on Alcohol. So that is an association in the United Kingdom where doctors, psychiatrists mainly come together and discuss the issue of alcohol use and abuse. The interesting thing is, it is not only about alcoholism, it's also about alcohol. And this may be a bit surprising, but you have a very restricted way in Sweden of selling alcohol, and I think it's a good thing. That doesn't exist, I think, anywhere else in the world. Systembolaget. So in UK we have licenses. In a way, you should think a license should be just as efficient as a Systembolaget. But price is the key to the consumption for the heavy dependent drinker who can only afford the cheapest stuff. And he would drink as much as he can. And therefore, if you have minimum pricing, we know that from countries like Finland who have experimented with price, that it has a huge impact on the deaths of the most dependent, on the really most suffering. But you would not believe the discussion that in Scotland we had with the parliament, with the the drinks industry, they were fighting about it. But I always thought, what are they bothered about? The whiskey that they sell, which is a huge part of Scottish economy, is not the stuff that any of my patient drinks. It's much too expensive. That is not the substance for alcohol dependence. It is the white cider. It's called White Lightning. Nice name. Buckfast. It's stuff that is only full with alcohol. That is the thing. But if you make that more expensive, then you can control the amount someone can take in, and it has been proven. But it took years of legal discussions, and that is something that this council does. So it's a very interesting organization, and the conferences that are done by them are usually very interesting, going in many fields. Anyway, the editorial that Jonathan Chick is one of the editors who works in Castlecraig with us. And he's written an editorial for this May issue about the unhelpful prescribing and alcohol use disorder. And should you have access to this magazine, or if you want that, I can send that to you as well, the editorial, where he writes a lot about the antidepressants, antipsychotics, benzodiazepines. I guess gabapentin and pregabalin is becoming a problem in Sweden as well. How to deal with these things. Yeah. You need to very critically think about all these questions and ask yourself, is it all important if you are a doctor? And if you have patients, if you're not a doctor, in a team where you see them outside even before things come to the worst, I could only reiterate what Åsa has said. Encourage them to see their doctor about possible reduction of their medication, because it would clear up their head. And quite a few of the problems that patients have come from the interaction of medicines rather than from the not having enough of it, you know. And the thing is, there is lots of evidence. I'm not just talking as an esoteric who has a certain belief. There were studies from the 90s that were looking into the use of antidepressants, of particularly SSRIs, and they seemed to rather increase the craving for alcohol rather than reducing it. Some case history from Atigari said, well, this guy only started drinking once I put him on an SSRI, so do we want that? This study just found there's no significant statistic difference that the day of heavy drinking after abstinence under an SSRI would make any difference. This is not statistically significant, 23, 26 days. You know from the Swedish register that SSRIs can increase violence. They are very problematic medications. SSRIs have liberated many patients with anxiety disorder or compulsive obsessive disorder. It can be quite liberating. I'm not saying these are bad medications, but they are often used in a bad way. That is our decision of doctors. Yeah? Another study that would really support the stance that we have just been talking about. And although you can't do detox with fruits only, you should still think what medications you use for it. Thank you very much.
Thank you, Florian. You're going to have a cup too, you know, so yes. It was nice to hear you talk about, and also talk about that you can get happy in many ways. Yes. And now it's even in Harvard known that the research says that gardening makes the intestines to develop more serotonin, so we get happy.
Absolutely.
And I knew that because it's...
We have a garden as well in Castlecraig. There's a huge old walled gardens. Do you have the walled gardens in Sweden as well? These
is fantastic.
Kind of from Baroque times, really, because there's so much wind in Scotland. If you have no wall, you can't really grow things specifically. So we start using this walled garden on our grounds as well.
You know what surprised me, as you said, you put them in the therapeutic context and the groups and everything. And I met especially one guy, he was still psychotic, but he was a part of the group. And he felt not alone and not so different. I gave him a hug. And, you know, it was really nice to see. Because we don't do that in Sweden. But I like the touch of it. He felt a part of, even though it's delusional a little bit.
It's a very strong power, I would say. Yeah.
Yes. So thank you.
Thanks for the invitation, Mikael.
Yes, and a hug for me.
Thank you very much.
Okay, salad